All right. Welcome to Planetary Health First, Mars Next. This is Bring a Friend series, Reimagine Health Together. And we have some really amazing guests today. We have Norma to my right, and she is VP of Data and AI at Nanya, and also an EIR at Yale Ventures. And that's an intern and, entrepreneur in resident. And to our left below is Jacob Reider. Readers, forgive me. All right, either or, we're fine. And Reider,
like the truck.
All right, like the truck. And we are going to be on a journey today. We're not going to go to Mars, but we are riding along healthcare journey. And just a few things to mention of him. He's been in healthcare. He's no stranger to healthcare. He's been on several boards, and he's an MD. And some of the companies, he's CEO of Huddle Health, former Circular Health was another one, CEO, former Alliance for Health, for Better Health, and a few other boards. He can get into that more. And then also we have a good friend of mine, Corbin, and she is, man, I tell you, if I remember correctly, she really did amazing work in Massachusetts, making healthcare right there, a former bit, but of recent, she's been leading the charge at several several companies as advisors, not to mention from Journey, NeuroTrack, Wave, Pair as a VC. Gosh, I don't even want to mention all of them. I'll let you guys, Norma, if you want to start. There's too much that just to mention with all these guests. So Norma, if you want to just mention just a little bit that I left off, please. And then we'll go around.
Sure. I'm a PhD health economist. I think of my career as sort of like three facets. I started as an academic, and then I left academia in 2016, fairly quickly. And then since then, I've been working in data and technology in different capacities. I was senior director of data analytics at the American Hospital Association, and also worked with Anthem later on in their new ventures in digital health incubator teams. I launched my own company, Empirical Lab, and then now I'm at Naya as VP of Data and AI, optimizing employee benefits. So happy to be here.
Glad to have you. Jacob.
I am a simple family doctor and have spent about 35 years at the intersection of health and technology. And like Norma, I started in academia, but I left in 2006. And have been in industry. I was the deputy at the Office of National Coordinator, ONC, for 3 years. And for a little while in there, I was the national coordinator between political appointees for about 6 months. I've worked with startups. I've worked with VCs. I am an LP in almost now 2, soon to be 3, early stage startup venture funds. And these days I do consulting with health plans and startups, and I play pickleball as much as possible.
Corbin.
Hey, Michael, thanks for doing this. This is fun. Corbin Petro. I spent my career like the others here in healthcare, past 25 years, really focused on delivering better care to underserved and vulnerable populations, designing unique payment models, and then integrating across those technology and data. So early part of my career, my first job ever was actually at Epic Systems. So it was very small at the time, but has obviously emerged to a big EMR platform. But the last 10 years, I've run 2 organizations. One was a payer-provider joint venture. So I ran a health plan through that, really focused on identifying and addressing social drivers with some of the most vulnerable populations. Most recently, I founded an organization called Eleanor Health, raised a little over $100 million to scale that organization, focused on addressing the unique needs of people with addiction and other mental health needs. And now, as you mentioned, I'm advising about 12 organizations from seed to Series C on the healthcare side, all founded by underrepresented founders, working with a couple private equity and VC firms to help them, navigate their diligence and understand the healthcare climate. So excited to be here and excited to spend time with Norma and Jacob.
I'm so glad all of you are here. I want to say that I really handpicked having you here to really get a nice, not like a motley crew, a tapestry of delight with like orchestra, with the right symphonic mix. And I'll stop while I'm trying to mix something up. And that's really to try to get this concept from provider to partner, transforming healthcare systems, because I feel like each of you have a unique perspective to offer. And so what we want to do today is drive what really has to happen to make this possible. And does anyone want to take, start on that?
I'm happy to start. I think, we're trying to get at, I think, Michael, how to bring sort of the provider side of the equation, how to bring them into being partners, and that could be partners with health plans, partners with patients, and I think a lot of that comes down to re-educating the provider workforce. They're trained, and I love Dr. Reider here, his perspective, but they're really trained to come in and provide an acute intervention. And so how do we better equip and train providers to be thinking proactively and longitudinally about patient populations? And how do we give patients the tools to interact with providers, to work with them, in an ad hoc way, use data and technology to tee up various interventions? And how do we align incentives such that, we're paying providers for that type of holistic care?
Jacob, you want to respond to that? Go ahead, please.
Well, you said we were going to have fun, so here we go. I disagree, and I think that I agree with the goal. So if we're talking about like the top of Mount Fuji, which is everyone's healthy all the time, and we don't need to provide care because everyone's healthy, right? That's our goal, and I think we agree with each other on that here. I'm not sure that N generations of providers, and when we say the word provider, I want to assume we're talking about physicians, but also other medical, and I'll make that distinction, medical providers. For 5 years of my career, I was the CEO of Alliance for Better Health, as Michael mentioned, and that was an organization that was singularly focused on working upstream. So we included in the definition of provider, social care providers and behavioral health providers. And the way that I thought about health, space, care, I always spell them with two separate words with a space between, because I don't think we can conflate the concepts. I think we achieve health if we understand that providers, or service providers, as I like to call them, are social care providers and behavioral health care providers first. And the tertiary component is medical care providers. And I think that the best path forward is actually not to try and retrain medical providers. I think they actually do what they do reasonably well. And all of our attempts to change the way that they approach their work and sort of try and get, surgeons to think proactively about, cardiovascular disease is crazy. And so I think we should love them for who they are, and not wish them, sort of like with our children, right? Not wish them to all like be whatever, dance with Baryshnikov and play with Yo-Yo Ma. Like, we want to love our kids for who they are. I think we should love medical providers and hospitals even for who they are. Yes, create payment models so that they are less incentivized to maximize care and more incentivized to maximize health. But I don't think we can retrain them. However, I think the allies, and I'll shut up soon, don't worry. The allies and the way that we fill those gaps is to emphasize social care and behavioral health care, and then create that workforce and pay that workforce to do that work, to partner with people. I don't like to call those folks patients, because we're all people, and we're only patients when we are in need. And I think, again, thinking proactively, if we partner with people and we give people that support, it doesn't have to be the medical providers. So I will go back on mute.
Thank you, Jacob. Corbin, do you want to reply real quick to that, Corbin?
Yeah, I actually don't think we're that far off. I think my point was sort of how providers are trained is to do that acute intervention. It wasn't necessarily to retrain them in their jobs, but to equip them with the tools, and you use the term better than I did on providers sort of expanding the definition. I too believe that there are other resources, whether that's technology or people, who should be sort of surrounding the human, the person, with the right types of care, social, behavioral, reminders, nudges, those types of things, and allowing the providers to deliver the care that's best for them, or having tools at the point of care so that they can provide some of those more proactive interventions as well. So I don't think we're that far off.
No, but it's more fun if we disagree a little bit.
That's true. That's true. You're totally wrong, and reschool everyone.
So Norma, would you like to? We'd love to hear you.
Well, so I think a little bit in different terms. I'm an economist, and so, and I think, forget about being an economist. I mean, I think of where I'm from. So I'm from McAllen, Texas. And so I'm thinking, when I think about the title, provider to partner transforming healthcare systems, I mean, I really think about my experience growing up in McAllen, Texas, and the types of partnerships that make sense. I mean, up until very recently, there wasn't even a medical school in the Rio Grande Valley, despite having some of the highest expenditures per capita on healthcare. And then I think of my experience working in Philadelphia, where even though it has, multiple medical schools, multiple large health systems and clinics, access for underserved communities is still so difficult. And so the types of partnerships that are needed in a place like McAllen, Texas, in terms of, basic access to primary care, preventive services, and then chronic disease management and prevention, like from both that intersection of public health and healthcare and health resulting in health, it looks substantially different in McAllen, Texas than it looks in Philadelphia, even if I were to say just for this income bracket, just because the access to the resources, community-based organizations, healthcare providers, medical access is totally different. And so I think that what it gets lost when we speak in this sort of like platitude style is that it's not one country, it is one country, but it's not one type of approach. Is almost like you have to optimize for the resources that are in the ground, in the conditions. It's not even the condition, right? Like if you were to treat an underserved patient or a patient with like it's low income in a hard to reach community in McAllen, Texas versus in Philadelphia, what you have to play with, the partnerships that you could even synchronize are substantially different. And so I think that that's what gets lost sometimes in these conversations.
Jacob, Corbin?
So one of your people, a character named Len Nichols, I'm sure you know Len, talks about this term called the trusted broker. And it's something that I really like because I think it aligns with what you're saying, which is that in the community, you can't have or in the, for the nation or even for the world, you can't have one size fits all sort of payment model, for example, right? And so the trusted broker is Len's concept of saying, okay, put somebody in the middle. And the way I translate the term to myself is like, it's the peanut butter on the English muffin of a community, right? And so because when health plans make certain investments in trying to work upstream or with behavioral health or something, then what you get is the wallet biopsy, right? It's like, at the food pantry, if you have this color card, you can get that. And if you have, housing instability, you can get it with that color card, right? And so, rather, you can create a social care network that works on behalf of the plans and the biggest plans, the government, right? So you get managed care, you get Medicare, and you could work with ACOs, with fee-for-service Medicare, or with Medicare Advantage, or with obviously Medicaid programs. You get this one social care network in a community that gets paid ideally PMPM, and then works with community-based organizations and even substance use disorder facilities, et cetera, to address the needs that the ones that you're describing, Norma. So then in the community, those who know the community can understand the needs of that community and address those needs. And clearly McAllen is different from, whatever, the artichoke valleys of California, or the inner city of Philadelphia, or Newark, New Jersey, right? But if that community has a trusted entity, and I think that's a piece that's missing in our country, is we don't have that layer of infrastructure. We don't have that workforce that is payer agnostic, that can advocate for the underserved and help them achieve stability, which then will prevent them from falling down the cascade of, social problems which beget medical problems, right? And then we have a reactive medical system rather than a potentially proactive one.
Any response, Norma, Corbin?
I don't disagree with any of that. I think it's something that, I've heard in the healthcare community for many years. 10 years ago, when I was running a payer provider joint venture, we tried to sort of build that in the state that we were operating, that sort of social community-based network. And it's largely based on humans, right? It's largely based on the social workers that know that community. They know what their patients need, and it's really hard to standardize it and to scale it. And so I think that's where there's a struggle. And how do we expand this to different communities, and how do we get the right reimbursement model for it?
So that's the core question. And I'm curious, since you've worked, sort of behind enemy lines on the payer side, how do we do that across payers instead of within payers? Because I think so when health systems try and do this, or when payers try and do it, or when payers partner with health systems, you still have a siloed effort, and it's not community wide. So how do we bridge that gap to go from pilot project intra-payer provider to community wide activity?
I think it's really hard. I'm trying to think of places where I've seen it work. North Carolina did a lot with Unite Us, for example, where they really took the reins at the state level to try to expand it, across payers, across systems. But I haven't seen it done well. I mean, when you think about who's gonna benefit most, it's probably the government that's paying some of the social costs. And so should this be an 1115 waiver for Medicaid to do something? Should this be a state effort? Should it be CMS? And you've seen out of CMMI with some of the new payment models, they're starting to pay for the services that I think create some of this glue, care coordination, and with the guide model and IBH and all these new models coming out, it's largely paying for those wrap services for different subsets of the population where they know they're so expensive and they know based on evidence that it's these wrap services and coordination that's necessary and leads to outcomes. So they're paying for that sort of glue in between. But it isn't clear who's that trusted broker. I think that's the missing puzzle piece, as you're describing it, Dr. Reider.
Yeah. So New York's new 1115, I think, tries to build on what North Carolina did. It's called NYHER, the New York Health Equity Reform waiver, which is starting as we speak, and they're trying to create that trusted broker. So it's a good point that government is probably the thing that advances. Norma, and not like I want to be MC, but I'm curious, and these are things I'm asking questions because I don't know the answer. As the economist, when you look at the sort of alphabet soup from CMMI, right? It's like every couple months there's some new innovative model, right? And I'm a health policy person, as are both of you. My head spins off. Like, I can't keep track. And if we can't keep track, how does an economist look at this and say, wow, it's the model of the month club. Here we are again at CMMI. Is that like, how cogent is that as sort of an economic policy principle, concept, whatever?
So I will say for the last few years, I haven't been following the policy aspect so closely. I'm very familiar with DSRIP, so the state of New York, back when I actually was just working as an academic back in 2014 and 2015. I do think that even though it can be overwhelming, that there's all this sort of like acronyms and efforts going on, I do think that the evidence does, accumulate and has resulted in very good insights. I think the impact, at least this is probably not what you were expecting for me to answer, but I think that the impact is that it gives the incentive and the rubric for teams on the ground to navigate change. And so how long have we been talking about value-based care? Probably longer than, it makes any sense to have not implemented it yet. But efforts like the ones that you're describing, certainly like the one in North Carolina, it really does align teams on the ground to do something in concert, gives them the steps and the rubric and the payment model. So I think that when we say, is the payment model aligned? Yes, that's true. But I think that is also that it gives everyone something to look at and a roadmap to work to. It sounds so simple, but I really do think that that has a lot of the change that we're hoping for, is until we get this sort of series of guidelines that everyone can get together. And we may not always agree with those guidelines, but at least gives us something to work towards to in unison. I'm sure that was not exactly the answer that you were expecting. I do think that the evidence is valuable. I do think that CMMI has brought up a lot of evidence and, orchestrated a lot of efforts. I don't think that only the public sector should be working on this. I mean, I think that I think that they will be, as Corbin was saying, the largest beneficiary because of the social services, or rather the lack of social services results in a lot of use for the public services later on, Medicaid in particular. I do think that the private sector should be more vocal about this. And I think that there's a huge part in power that I think that employers could have in demanding some of these services and some of this access and this layer and social layer that we're just not really coordinating in that direction. And we could and we should.
I have a question that I'd like to just put to the audience. It seems like, this is from a personal experience. My father's 91, he's in hospice, but I feel like 30 years ago, he could have been a full wraparound support. But I wish there'd be more initiatives. It was pretty clear that he wasn't a good candidate for any surgery. All they've been doing is CAT scans, MRIs, and I feel like, why aren't there more of those sort of things? And it seems like the health systems still they want to have people admitted. They want to all do the sort of things. I wish, are there more initiatives like that? And that was just the example, and I'll be quiet because you guys go ahead.
Well,
I think.
Go ahead.
I was going to say, I think part of the challenge of CMMI and 1115 waivers, they're all experiments. They're all pilots, and they're all framed as pilots. One of my favorite programs is the PACE program, the program for the all-inclusive care for the elderly. And it's the, it's sort of the holy grail of value-based care. It's very whole person. It's for, the most frail elders. It's sort of a sort of day program where older folks go, they get all of their needs met. The reimbursement is, a capitated model, super expensive. It was initiated maybe 30, 40 years ago. It's still a pilot. So like some of these models are never, it hasn't been scaled, but are some of the most successful models. Well, why isn't it scaled more? So I think, to your point, Michael, and Norma, really, there's very local nuances to a lot of these programs. Even when you look at Medicaid in different states, and, expansion is in most states now, but not every state has Medicaid expansion. And that really supports various initiatives and how the MCOs and others sort of wrap around those populations. And so it's a question of like, how do you scale things, but also like, how do you keep things local? Because that's really how you get to the most effective models.
PACE is locally sensitive in that way because of its payment structure, right? And it is fascinating that these things are still pilots 500 years later, or so it feels. Michael, my dad had cancer and also was in hospice. What's interesting about my dad's experience, and perhaps yours, my dad was a physician. And so an interesting nuance of how physicians die is that they don't die slow, right? You don't see physicians spending 8 weeks in the ICU and do everything, right? And my dad was very intentional about making sure that he had a long life and not a long death. And I vividly remember his personal conflicts with physicians. So I think, addressing sort of your high level question at the top, like it's human nature to want to be successful, right? And, as Corbin mentioned earlier, we're trained to respond, react, and we are trained to consider success as doing the thing that fixes the problem, right? And my dad had these deep arguments with his best of the best oncologists who didn't want to give up, right? They saw it as failure. And so doing the extra test and doing the extra intervention. And he just said, hey, screw this. I'm done. Let me go in peace and not, have to die in a hospital. And, I think there's still a subset of the community that is, advocates for themselves in that way. I think hospice helps give us the words and helps us process these things as families. I do think, and I'll conflict with myself from what I responded to Corbin with earlier, I think we could train the future physicians to think differently about this. As a former medical school educator, I can tell you that they're fertile minds and they are wonderful human beings. And, in their medical school interviews, they all talked about the altruism with which they were approaching their profession. And they're not yet jaded, and they're not yet caught up in the, hey, we have to succeed, and success is I fix the problem, right? And I think this mindset permeates health plans, health systems, and medical education. And I think there are ways for us to start to evolve that. But I think that's the only answer to your dad's problem, and he's probably not going to live long enough to see it change. Not to be morbid about it.
Yeah, no, he's a retired internist, but I think also the personal experience makes it so difficult. So you have a family dynamic that makes it so difficult for my mom as a primary caregiver that didn't want to give up. But it was finally when she had the palliative care nurse practitioner the last time that educated her, that took the burden off her. That guilt, all those sort of things. So it seems like that's the most important thing in healthcare that's just not lacking. And that could have happened a lot longer. And then it's so confusing, whether it's palliative or hospice in every different city or county, or it seems like it's different. So I do feel like when Corbin, you talked about pace, it seems like going forward, we're not going to be able to spend enough money chasing the ball with, it just seems like we need to have an opportunity to do these initiatives, because it could have been not hospice, but maybe community-based care, a more wraparound IVs, but MRIs and CAT scans. In hindsight, 3 years ago, just seemed like no one wanted to call. I think it's a leadership and a culture challenge too. So anyway, I'll stop because it's your time.
I think some of that's primary care also, right? Or what I like to call primary health. Like the primary health provider, it's our job. Like family docs, we're trained to do that. Like we're trained to have those conversations. Unfortunately, unlike many so-called primary care doctors, even internists don't get the training that family docs get in, sort of addressing these issues 5 years before it's time to address them, right? And I think that's what you're sort of expressing, is we got to have these conversations, and it also takes a family. Maybe your mom and my mom should talk. My mom was pissed, like really pissed. She was pissed at my dad because she felt like he was giving up. And it took her 2 years. 2 years later, my mom finally forgave him and saw that sort of that was likely the best path for her and for him, because being the primary caregiver for someone who's got a long death is really, really hard work. And
I'm helping on Sundays do the showering. I mean, it's really, we luckily have a caregiver, but that's 36 hours. But anyway, Corbin, I'd love to turn it to you. You're like a behavioral, I mean, what you did with Eleanor, I feel like that's a huge element, because what I didn't realize until recently, 42 to 53 is the fastest growing population within Medicare. And you don't ever hear that. And behavioral health is driving a lot of the costs. So that, to me, should be more of a topic. What do you think? How can we do a better job creating better awareness and better programs to solve that? Because it's not a healthcare system. It seems like the better care is outside of the walls of the hospital. So I'll stop there.
Well, I think yes and no. I think a lot of behavioral health interventions can happen inside a hospital, but to your point, some of the social drivers obviously are addressed outside of the healthcare walls, or beyond the time that you're with a clinician. So, what we did with Eleanor is we looked at the population who really struggled and was affected by addiction. And, 80% have another mental health condition, 70% have a physical comorbidity. And typically in healthcare, we're addressing, especially on the specialty care side, we're addressing sort of one of those conditions in a silo, instead of thinking, okay, how do we really care for the whole person here? There's a person here, not a condition. And so created, what I referred to as a specialty medical home. So it's driven by the specialist as opposed to the primary care provider. And that could be, led by a quarterback that's a peer or a sort of a community health worker type person. It could be a psychiatrist. It's really where, going back to that sort of trusted broker concept, whoever in that sort of medical home or that collaborative care design is building that relationship with the patient or the person, and can help sort of drive them to the best resources that they need, but is looking holistically across all of their conditions. Because what we saw was that addiction was so damaging to a person, to their family, to their social needs, their physical health, that if you really got that piece managed, you saw the physical comorbidities get managed, better because the addiction was managed. You had to manage the mental health condition in order to support the addiction. And so really being able to sort of see all those things together and then align incentives around it. So taking, we would take risk or be sort of paid in a subcap, capitation subcap, different ways to make sure that the services that we were providing, because we felt it was incumbent upon us, since we were spending so much time with the patients, to really address all of their needs. So that was, I think that was the model that we created at Eleanor. And I think there's a place for the specialists to really take the lead in driving, some of the sort of care coordination and the whole person orientation for certain populations that have chronic conditions. And that, that could be the specialist. It could also be a community provider. Or a community, non-clinician or a non-licensed person who's built a relationship and understands some of those social drivers. And I think it's expanding that definition of health to be all inclusive.
Norma, would you like to respond back?
Yeah, I think that, we probably, everyone has experienced it, right? There's a lack of access to primary care just by the function that we don't have enough primary care and family doctors, right? And so that's, it's sort of like a statistic we haven't been able to break, but we have the proportion of specialists is larger than the proportion of primary care and family doctors. And so the question then becomes for many of the needs and many even of the specialized needs that someone might have, you still benefit from having someone helping you navigate, translate, educate, like Dr. Reider mentioned, have necessary conversations about your health and your family. And the question becomes, then how do you resource that? And I think like what we're all kind of converging is saying that that layer is missing so much, and in some places and conditions, and is so absent that we need to do something about it. There's a role for technology, I think, to play in this. There's a role for skilling folks in different careers, different professional journeys. There's a role. I always think about just sort of like career mobility and changes over life, right? I've held different roles as an academic, or then in technology, or an entrepreneur. And so it's interesting how often do people come in and out, and perhaps being in a role where, being a caregiver or a specific type of working in care navigation is one of the roles. And it doesn't seem to me that we speak of this sort of what is the quality of these jobs? Can we make this profession, occupations, more appealing? Because the gap is so substantial that to me is just like, we can continue talking about it, but it's sort of, what are we doing? And how do we make this profession and occupations just much more appealing than they are today? Because we're all suffering directly or indirectly. And I feel at some points of our lives, we'll always be directly, either ourselves or our family. And so I think that my prior company worked in the aspect of upskilling and peer-to-peer training and healthcare and allied professions. And, it can be beyond puzzling. Why are we not investing more in that space, right? And so I think that that's perhaps something that I'd be interested from Dr. Reider, Corbin, to hear your thoughts. And that we've known this. I mean, I finished my PhD in 2014. The last 10 years, I don't think the statistics have changed. We continue to have more specialists than primary care doctors. We continue to have this gap, this huge gap, and this layer of connectivity in the healthcare system. And so what could we be doing, or what, should we be doing to just stop talking about it and do something?
It's all about the money. It's all about reimbursement. All about reimbursement. I mean, we don't pay primary care docs at all, not well enough. And specialists, I don't know what lobbying groups they have, but man, they just keep getting better increases, and the delta just continues to exist or increase. And so it's really hard. If you're a medical student, you have debt, you have, these paths in front of you, you want to help people, you come in, as Dr. Reider mentioned, with the best intentions, and, specialists change lives, primary care change lives. And it's the difference between the compensation and the reimbursement is vast. So
it's vast, and it's also culturally, primary care is culturally maligned in academic medical centers. Like, let's just call it what it is, right? Like, I was told 20 years ago, 30 years ago, when I was in medical school, 30, that I was too smart to be a family doctor. Like, I was told this by one of my mentors, who was a specialist. So the fact that we create doctors in facilities that are largely run by specialists, it's no surprise that, they are modeling the behavior that they seek to see in their offspring, right? It's, again, not to be too paternal about it, but it's just like our children, right? We want our kids to be like us when they grow up. And go ahead, bring it on.
Can I push back that? I mean, the focus is being a lot in the clinical professions, but we're all talking about a layer that is so absent and that would benefit from folks that are not clinically trained, right? That there is the aspect of navigation, there is the aspect of connectivity to resources. That is probably a type of skill and competencies that you don't need to go to medical school for, right? And I think even when we speak of there have been initiatives by the federal government around, nursing, right? And I think rightly so. There's a huge gap and need for nurses and nursing training, and so we should do it. But I don't see the funding flowing to this gap, this layer, right? We sort of keep kind of hoping. And I also disagree even a little bit that it's about the payment model, because we do have functioning private sector, opportunities in some regards. We haven't developed let me put it this way. I see it like at the end of the distribution. If you're incredibly wealthy, you can afford, 24/7, care, and it's going to be super expensive, and that's all there is. And if you're not, you're out of it, right? And so there has to be, because we're all needed, right? There has to be a model around that. And I don't think that we're innovating there. Everyone gets more excited, I think, for financing, I don't know, kind of pie in the sky idea. This is probably too concrete to be fundable. This is just too straightforward.
Do you mean funding like care coordination or, a non-clinical workforce that's supporting on the social side?
Innovation, public-private partnerships could be innovation at that level. Yes. I mean, we've seen it, I think, in some regards. I do think that there are some mental health solutions that do some of this. You've seen it also when you see companies that are doing virtual first type clinics or virtual clinic model for specific type of specialty care. A lot of the layered of that delivery model is non-clinical workforce, is coordination, is navigation, is all of that. And so you do see some models, but they kind of don't specialize in this more general health, almost intersection with public health aspect that we're talking about. Or maybe I just don't know about it, but I haven't heard of innovation in that space.
No, they focus on the highest cost populations because you can get an ROI, right? I mean, I don't want to make it all about the money, but it's about the money. And I think that's where some of the care in that sort of middle non-clinical wrap services is being covered for certain populations. A lot of states cover peers. So peers are, they make them get some type of license in most states. So they sort of force some licensure. There are a lot of private organizations that are providing coaching, for example, on the mental health side. Those are sort of, empathetically trained, but not therapy and clinically trained. There's community health workers for the Medicaid population that have been either reimbursed or part of capitated models for many years. So they're in there in fits and starts, but you're right. It's not in a sort of proactive sort of population or public health way that I've seen at scale. It's more focused on certain populations that are the highest need. And maybe that's from a population and a public health perspective. Maybe that's actually not a bad approach. I don't know, Dr. Reider, I don't know if you have any thoughts there.
Gosh, so much. I think we're mostly on the same page, and I agree. And sort of that's where I was going when I was supposed to shut up. So I did. It's not just primary care, right? It's primary health. And if we're really thinking primary health, then in the setting where we would train the future workforce, we exalt the people at the front lines who are the social care providers. And those are the community health workers and the health advocates. And you don't need 4 years of medical school to be a really good coach, for example, right? Learn motivational interviewing and get with the program and learn some terms and be an advocate. So I think it's there is a next wave, but I think to the points of both of you, we've not yet turned that corner. I do think that there is an opportunity for, some framework of virtual services to fit in. I think there's, we've only said AI like 6 times today instead of 66. So I think there are opportunities for generative AI and other, LLMs to play a role here. I think we need to do it cautiously, but I do think that there are opportunities to leverage that as we better educate, as we better empower, as we give people more information. My final point, I hope, is it's also about control, right? My occasional engagements with the payer side, sometimes they don't want to let go and embrace a new model, even though there are providers. I had an adventure where I owned a primary care group that wanted to do, we wanted to take on lots of risk, and I got patted on the head by a bunch of health plans. And oh, Jacob, you can't really do that. You're not smart enough. And they were like, let's keep it fee for service for now and see how it goes. And I was like, no, I want the risk. So I think part of that was, again, kind of human nature, want to stay in control, like the way it's working. It's not, if it ain't broke, don't fix it. And from the perspective of many, it actually ain't broke, which is the opposite of what many recipients of services would say.
Before we finish, can we at least throw in VBC, value-based care, and another one, AI? Since Norma, you got AI in your title, I feel like we got to get those search engine optimizations going with LLMs. Thank you, Jacob. So if we can just finish a little bit on that, please.
And I'm like it's so funny. It's sort of like I appreciate that it's in my title, and obviously I get asked a lot about it, but I've been working with data for many, many years now. It is all about actually having it in a clean, reliable, accurate way. We have opportunities to increase the latency and with which we get the data, and so it's flowing much faster, and we can do many more things. But before we get into true AI, we have to be really ready. Perhaps the one thing that I will say that is very relevant to the conversation we're having is that when you are designing products with AI in mind, you have to be so much more conscientious about the experience for the end user, because now the navigation of that experience is going to be different. And so I think that everything that we're touching upon today, end users with lack of access, cities and states with different resources, and so I think all of this nuance is really important to have. So I'm here to say that we're here first to get ready for it and be very intentional before doing any crazy things.
So we don't want to take Cerner and Epic and just upload it all.
No, and I will say probably the most important thing that you have to have is actually that you trust the data that you're ingesting before you leverage AI tools. And so I will say, I will just posit that a lot of the data that we work with in healthcare, we have to be really careful. I mean, when you think of, billing and all of that, you have to be really careful and how reliable and trustworthy that data is, how many times it changes and everything. So no, safety first.
Yes, I did a panel about 5 years ago called The Wild West of Analytics. And, today it would be called The Wild West of AI because, I think there's always unintended consequences when the technology is moving more quickly than people can regulate and people can understand those consequences. I think we saw it with Google's Gemini, where they put out a product that people trusted the way they trust Google to do search. And there were pretty bad results from that because it was, not, they put in different things to try to make it a little bit more woke. And that ended up producing results that were just, historically and factually false, which, has consequences at some stage. And I think if you transpose that onto healthcare, it all depends on the data and how the data is learning from it. And, historically, we've done a really good job of researching, white men as part of our research in healthcare. And so making sure that our AI tools, it's all based on what's the data set that it's learning from. So making sure that that's intentional, particularly when it's focused on people's health.
And perhaps I'll be corrected by the health economists here, but I think of of two sets of stuff. One is data, which I consider to be like the stuff that's transduced directly from the natural world, a blood pressure, an X-ray, etc., and information, stuff created by humans, the interpretation of the X-ray, a diagnosis. And in some of my early work, with a couple of startups, it turns out that information's about 50% wrong, right? Data is data, information's potentially wrong. Your diagnoses are wrong, your ICDs are wrong, your Snowman CTs are wrong. And therefore, if you're training an LLM on information and data, your LLM is going to be really confused because half the information was wrong. If you're training the LLM on data, or you understand to upweight it, and I have not seen in all of the discussions of health, space care, and AI, I've not seen anybody talk about this. And I think that this is a really big topic that probably needs to be addressed to make your point, Corbin, right? Because you do the wrong, you have the wrong information and data set, you'll make the wrong predictions. And if you make the wrong predictions pretty soon, and it's probably happened and we just don't know about it, bad decisions will be made based on AI helping. And to your point, unintended consequences will be aplenty. And then the regulators will try and catch up, and that'll be really hard, said the former regulator.
Norma, would you like to respond?
I agree. I mean, I think that, like I said, I mean, I think that it's a tool, right? And so it's a way of doing things. We've been using machine learning for many years. We've been using AI actually in vision for interpretation of results and imaging, for many years as well. And so the tool that I think we're all speaking about right now, it's LLMs, generative AI. And so obviously it's a tool that is very helpful to be pointed in certain directions. Like it's really good at summarization, for example. So if you have a reliable body of data that you need to summarize, it's very good at doing that. Obviously in healthcare and healthcare training, for example, we have a lot of that type of reliable sources of data. We have a lot of it, and we may need to summarize it. And so I think that is where and how you point it. I will say that in my years as an entrepreneur, what I found was that when I was talking to people in healthcare or product developers and working in the healthcare delivery space, a lot of the initial applications and the big marginal benefit was in internal operations and efficiency before it would touch patients, right? And so a lot of it was, well, we have a lot of information and we get lost. How do we summarize this information or get to this information? So contextual search, for example. Contextual meaning that it understands like where you are is this body of work, but you are at a hospital in this region, in this area. And so it just provides contextual information. Summarization, very good at that. Initial, sometimes in the space of node writing, for example, you sometimes need to start with something. So it's really good at get you started for you to then come later and edit. Those are things generally those type of applications don't necessarily need to touch the patient, but it can have a huge influence in patient experience if the operational machine of healthcare delivery improves and uses these tools. So I think that the first set of applications will be on the operational efficiency for organizations before it moves into meaningful changes for patients. The more meaningful changes, we are seeing it right now, right? It's just that it's more empathetic in the way it, conversation. And I think that that's why everyone thinks or has a chatbot in their mind. But there are many more applications that we could be doing. But I think that, again, without proper data, reliable data, and safety, we shouldn't. And so therefore we're not.
Thank you. As we wrap up, we're kind of coming to the end. I would love for all of you just to touch on VBC, value-based care. I feel like if we're talking about transforming healthcare, even if it's just a one sentence, a thumbs up, thumbs down, I think that would be only appropriate.
Oh, I mean, I'll start. It's value-based care is something that has been pretty consistent in my career. I'm known for being a big fan of value-based care. I think, like all parts of life, incentives, and how we think about incentives and how we deploy incentives, it really tells people what's important to us. Just like we had the conversation earlier on primary care versus specialists, how we pay for those tells us, that Dr. Reider's too smart to be a primary care physician, right? Or a family doc. So I think there's a lot of promise in value-based care. We have to be able to administer it in the right way. And I think we have to find the right models for various populations and not rely solely on what we've done, which is, primary care capitation is sort of the main one that we've done. And some bundles. I think there are other models that we could benefit from for different populations, different conditions. So I still feel a lot of promise in value-based care.
Norma, Dr. Reider?
Definitely for it. I mean, it's the way that we should be doing things. I think that I am frustrated, I guess, just as just as a person, not as a health economist or someone who's worked in the space, but just as a person, frustrated that it continues to not be even the majority of how we do business or how we deliver healthcare, how it happens, contract agreements happen. So it's frustrating that it hasn't moved faster, but definitely for it. I think that the challenge that I've experienced when I don't work fully in healthcare today, but when I worked in healthcare, is that it's a data commitment. The value part of the equation needs to be very clear. Like, what is value needs to be defined. And perhaps, surprise to no one on this group, but perhaps surprise to some. Sometimes defining what that value is difficult, and getting the data to prove that is value is difficult. So I think that's one of the inevitable hurdles of it.
Jacob?
Yeah, look, conceptually, I'm a big fan of what we call value-based care. I'm the CEO of a REACH ACO. So, and I think the REACH is a really good model from our friends at CMMI. But I think, to Corbin's point, we need to think a bit, broader than ways to capitate or other things. I think specialists often get left out of the picture. And I think, having provider organizations own all downside risk is probably a mistake. Insurance exists for a reason. But shared savings is interesting and allows organizations to understand and build an interest. And this is what I've seen in, with the ACO. It's like there's a little light bulb that goes over a doc's head. It's like, wow, my patients who are on these biologics, they're costing us, hundreds and hundreds of thousands of dollars. Are they necessary? And, we haven't talked about the new weight loss drugs or anything like that. And that's probably the topic for another day. Be interested in Norma's perspective on that from a health economics perspective. So I think, look, there's all kinds of opportunity, but I'm concerned that we've got cookie cutters so far and have not been as creative as we could have been.
Well, this has been amazing. I think we really had a great start to transforming healthcare with, the vision. So glad the three of you could make it today, and we are still friends. Are we all still friends today? All right. Until next time.